Welcome to the External Medicine Podcast. We are here with Dr. Andrew Foy, a cardiologist and associate professor of medicine and public health sciences at Penn State College of Medicine. Drew, welcome to the show.
Yeah, thanks for having me. Excited to talk to you guys.
Before we get started, do you have any financial disclosures?
No.
Excellent. Before we get into some of the papers you've written and some of your ideas, how do you describe your background and intellectual interests to people you meet?
I don't know. I don't know that anybody's ever asked me that question like that before. I don't know. So I would say that this is maybe an indirect way to answer that question. So, in high school, I was sort of a jock. I was into sports, but I did well in school. College, I really loved college. I went to a small liberal arts school called Ursinus in Eastern Pennsylvania. Really got into liberal arts studies as well as biology or biochemistry, molecular biology, which were my majors at the time. In med school, I went directly to med school. I found it really boring. And so I found myself reading a lot of things related to political philosophy, and just sort of doing what I had to do to pass to pass med school. And I think some of that reading sort of influenced the way I think about things in medicine, particularly as I was learning things in my clinical years. And I think I've always just been inclined to think a little bit differently than most of the people I work with in medicine. And so I've just, as now I'm a general cardiologist, clinician educator, spend most of my time seeing patients, which I really enjoy, and doing education related stuff with house staff, medical students. And all of my research interests stem from questions that arise to me in the clinical setting. And I've just tried to find ways to sort of address those questions with the research that is sort of available to me. I probably didn't answer your question, did it?
That was an answer. Yeah. I guess let's talk a little bit about the political philosophy you read in college. You've written a number of articles that reference Mises, Hayek. Was the Austrian school particularly influential in your reading? And tell me a little bit about your experience reading Hayek.
Yeah, so it was actually medical school when I started reading that, not college. And I just found it fascinating. I'd always been interested in learning about classic liberalism and the philosophy behind that. And then, I think that's what a lot of Austrian economics, that's sort of the foundation, the philosophical foundation of it. And then, the actual, Austrian economics is very much like a theoretical sort of economics. It's not so quantitative. It's not so sort of algorithmic and formula driven. And I found that very interesting. But probably, even though I was interested in the economic aspects of it itself, I was more interested in sort of the background philosophy, and some of it was driven by economics, but a lot of it was not. In pertaining to Hayek's work, specifically, I was really interested in Thomas Sowell as well. I read most of the economists and political philosophers of the 19th, 20th century, 18th century. I just found that very interesting at a time during medical school that I thought was otherwise quite boring, first and second year.
Krebs cycle by day, Thomas Sowell by night.
Yeah, and I'd already learned it in college, and I felt like, what the heck? I didn't think I was, going to have to do this again. But
so, I guess speaking of Hayek, you wrote a piece a couple years ago entitled "A Hayekian Defense of Evidence-Based Medicine." Can you tell us a little bit about that piece and why you wrote it?
Well, you guys are asking some good questions. You really went into the vault of stuff. I think somebody had sort of challenged me to write that piece, one of the editors on that particular website. And I've thought about that, and I'll tell you, the particular editor told me, he's like, well, you sort of effed that one up. And I was like, oh, I don't know. I thought it was okay. So, but he's, they still put it out. And I think what I was sort of driving at is that Austrian economics, to some extent, is grounded in this notion of sort of like what's real, and what's real is what sort of consumers subjectively assign value to something, and that value that arises, those price signals, they can't really be they can't be predicted so much, they can't be planned. And I think that idea was in my head as I was thinking about evidence-based medicine, and the signals in medicine and really come from, summary effects and treatment effects, and that sort of empirical approach, and that they can't be easily predicted. And so I think that I was sort of trying to tie those two notions of things that sort of arise sort of spontaneously, but provide something concrete that we can sort of grasp onto when we otherwise, can't always make a lot of sense out of things because we don't have the requisite knowledge to do so. And when it comes to like biomedicine, that's really tough. And I know that you interviewed Adam Seafood before and have talked about like Vinay Prasad and their work together. But that notion that sort of our best pathophysiologic understanding can't always predict treatment effects, and the only way that we can really determine them is from testing in a clinical trial. So it was not really the greatest analogy in the world as I think about it over time, but I think that that's really what I was driving at, was the idea that price signals in sort of a free market economy tell us something that's real, even if they can't be planned or predicted. And that was sort of the analogy what I was looking at when it came to evidence-based medicine and empiricism, which is results from clinical trials tell us something that's real and that we can't necessarily predict or plan otherwise. Does that make sense? And I don't think I explained it that way in the article. I think the editor was probably right. I probably did F it up. And I don't know that the analogy is that good, but that was the analogy in my mind at the time.
Have you thought at all about prediction markets and their relevance to conducting trials, like using the price of a prediction market in order to have a better understanding of what is true in the world and what is more likely to be true or less likely to be true?
I haven't really specifically thought about that, but it's interesting. I mean, to hear you say it. But when I think of some of the things in medicine that have turned out sort of not to be true, I think to myself that the majority of people at the time who had knowledge would have predicted the opposite. And so, yeah, it's an interesting question, but I haven't really thought about that too much.
And since we're already talking about evidence-based medicine, I think it's oftentimes people use evidence-based medicine, that term, when speaking negatively of things they disagree with, as, oh, that's just something you learned, but the evidence doesn't really support us. And there's a term sometimes thrown out, eminence-based medicine. How do you think of what evidence-based medicine is and what it has hopefully, maybe, possibly replaced?
So to me, evidence-based medicine is really just the process of critical appraisal and how we apply the tools of critical appraisal, and how we translate the results of research studies. And it's sort of a systematic way of going about that. That's really what evidence-based medicine is to me. I think the term, though, has been sort of like bastardized to me in a lot of different things. I think a lot of people use like evidence-based medicine as to defend practice guidelines, like incentives, hospital incentives, physician incentives. For example, something like X percentage of patients in a hospital need to get DVT prophylaxis, and that's evidence-based medicine. But there's really not a lot of evidence to support the practice that improves outcomes in the majority of these patients. And so, like, you're using the term evidence-based medicine to do something else altogether. And I think that as far as like the quality movement has gone, it's sort of co-opted, it's sort of taken some of the terms from evidence-based medicine and the idea in general and said, like, quality care is basically evidence-based care. And I think that it's oftentimes not true. So evidence-based medicine for me is really just a systematic process of appraising research and translating it.
On that note, what are some specific areas where your appraisal of the evidence, your view of evidence-based medicine differs from that of your colleagues?
Well, I'm a clinical cardiologist. One area that I struggle with a lot is management of patients with congestive heart failure. So, for example, as a general cardiologist and not an advanced heart failure physician, the patients that I manage tend to be older when they get heart failure. The mechanism for why they get heart failure tends to be usually ischemic or valvular. Oftentimes, patients have a lot of comorbid conditions. And these aren't people that are included in the clinical trials of our standard heart failure therapies. And so goal-directed medical therapy in heart failure has sort of become synonymous with this very aggressive approach of starting like 4 or 5 different medications all within a very short period of time, and with the goal of up titrating those medicines very quickly. And it's sort of become protocolized in a lot of places, and it says that it's doing this because the evidence says that it's the best way to treat patients and to reduce morbidity and mortality from congestive heart failure. And I actually know the literature very well, and I come away with almost a totally different perspective, which is, most of the individual trials that are talked about and used to support that practice, I think they're all more or less internally valid. And I think the individual sort of aspects of this therapy being beneficial or that therapy being beneficial are true in selected patients. But I think that the way in which we apply that now really isn't evidence-based at all. So even the notion of just starting patients on everything at once and very quickly, most of the trials, as sort of explicit criteria for inclusion into the trial, patients have to be chronic, stable patients, and they have to be sort of optimized on background standard care. And so what that equates to is that the average patients in most of these trials are like in their late 50s, early 60s. They're on they're basically on a diuretic at a reasonably high dose to maintain euvolemia. They tend to already be on a optimized dose of an afterload reducing agent and or a beta blocker. And then we're sort of testing these newer agents like Entresto or SGLT2 inhibitors on that background. And they couldn't have been hospitalized for like the last 3 to 6 months. And so that's very different than in, treating a patient in the hospital who's just had a massive heart attack and now has systolic congestive heart failure. And the question is, how do we sort of initiate and then titrate these therapies? Do we start all these therapies at once? Do we start instead like rather slowly? And once people demonstrate that they can't tolerate this or they're not responding well, that we sort of stop and don't keep pushing them on people. So I just think that it's a case of where my appraisal of the evidence that's out there translates into management practices that are very different than what is being pushed as sort of standard of care. And does that make sense?
Yeah, it reminds me of, so we did an interview with Carl Schneider, who's a lawyer who wrote a book called The Censor's Hand, which is about IRB regulation. And one of the points that he makes throughout that book is that IRBs, which are designed in certain ways to protect the most vulnerable, those being, women and children and minorities and people who are poor, end up, by virtue of how they're actually designed, prevent us from knowing information about how different drugs or trials affects those groups. So in a way, they end up harming those groups, because if you don't know how this drug affects a pregnant person or a child, what that means is that now, 90% of drugs are off-label for children as opposed to tested in that population, and you just know much less about pharmacokinetics or other things related to drugs in those populations. And the parallel here is that, maybe by not doing trials on the populations that you're actually seeing in the clinic, maybe that's done because they want the trial to be positive, because it's less likely to be positive if they take too many groups from too many people from populations from too many other groups. But it could also just be that you want to protect the person who is in the hospital and you don't want to give them a whole bunch of medications. And the downstream effect of that is that you don't know how the drug affects them. And then you start prescribing it for them outside the specifics of the evidence base.
Yeah, no, I mean, that's a great way to summarize that. And that's actually some of my main research interests now relate to the idea of treatment effect heterogeneity, and specifically as it relates to comorbidity burden. And so my group at Penn State, we tried to get as much patient level data from published clinical trials as we can, and then sort of do reanalysis of the trials based on subgroups of patients divided by comorbidity scores. And I mean, we've found some very interesting things. I mean, it's almost like I could have predicted them, in retrospect, but at the same time, nobody really has any awareness of these things. And I mean, we've published some of this stuff. We're in the process of writing it, more of it up. Yeah, I mean, I think it's like a fascinating area. I mean, I think most of our clinical trials are sort of designed to show proof of efficacy, which I don't really have any particular issue with. I think that's an important thing to do. I think the problem comes, though, in how we translate what they show us. And I mean, even, to give you an example where I think heart failure is sort of going so haywire. So, I mean, there's really multiple components of that. The first component is that most of the trials, particularly the ones that are the most positive trials, are done in these stable outpatients. What does that mean when doing this on more vulnerable inpatients and patients that are transitioning from hospitalization to discharge? And it's just sort of assumed that they're going to benefit, when in reality, I mean, they might not benefit at all. They might be harmed given their particular predicament. But then the second aspect is that, even if that might be true, but the patients in other ways may look exactly alike. They still might be the same age. They still might have the same, blood pressure profile, comorbidity profile. But then when you add into that the fact that the patients generally actually are a very different cohort of patients, you can make the case, like, what do we really know here? And why are we so confident not only in sort of applying this to these patients who are vulnerable and quite different, but like, we're just going hog wild with it. We're not holding back. It's sort of like more is better. And, that's the approach. And it's like, if you miss the opportunity, or if you waste the opportunity, you're somehow a bad doctor. And that really just that bugs me. that really irks me. Because it's one thing if you just miss the opportunity because you don't know, right? It's another thing if you purposely didn't seize the opportunity because you have concerns that it might actually be hurting people, and your concerns might be completely correct, because you can't tell me based on the totality of the evidence that I'm wrong. You can perhaps disagree and say, I think you're wrong, but you can't prove to me that that's wrong, and I have reason to believe it's right.
We've been talking a little bit about goal-directed medical therapy. You've also written about the lower systolic blood pressure guidelines as recommended from the SPRINT trial, adults over the age of 50, comparing systolic less than 140 to a systolic less than 120. Can you talk a little bit about the SPRINT trial and why you disagree with some of the changes in guidelines made from that trial?
Yeah, so this goes back to one of the first sort of topics that I was interested in when it came to critical appraisal. I was a resident at the time. There was the big medical reversals of that time was like PCI for stable coronary disease. We were learning some things about treatment of blood sugar. The ACCORD trial, for instance, came out where it showed that the more intensive glucose lowering arm had higher mortality. It showed that the arm where they tried to reduce cholesterol more didn't do better. And the hypertensive arm of that particular trial, the patients didn't do better. And so I got really interested in this idea that a lot of the recommendations that we're making in clinical practice are sort of based on observational data showing that risk changes according to these sort of observational numbers. But that's very different than then using the observational data to set these treatment targets or making them targets for intervention. So, it's one thing to say that a patient with systolic blood pressure of 115 or 110, when you look at the entire world population, who are naturally at 110 and untreated, they have a much lower risk than people who are 130, who, let's say, under the same circumstances. It's very different to say that we're now going to take a medicine and we're going to lower people from 130 to 115 and anticipate that they're going to derive the same benefit and they're going to look like that person who lived at 115. I mean, there's a lot of reasons that person lives at 115 is at 115. And the person that's at 130 or 140 or 150 is at those particular numbers. And doing one thing to lower blood pressure may or may not, have any significant benefit. And the only way to know is to test those things. And so I got really interested into the literature and the trials that were dedicated to sort of target blood pressure treatments. And one of the first big reviews I did was on that subject with a guy named Ed Philippone, who's a nephrologist in Philadelphia. And I mean, our conclusions were that there was really no evidence to suggest that lower was better. And we published that probably, 3 to 5 years or so before the SPRINT trial had come out. And we had also been interested in diastolic blood pressure J-curve and some other topics in and around blood pressure management. And so when Sprint came out, it was different in terms of it was positive, but there was a history of trials in that space that were negative. And so then it becomes an issue of, what does evidence-based medicine mean? It means trying to reconcile, the differences. I mean, why was Sprint positive and why was Accord negative? Why was Giotto's trial negative? Why was the HOT trial negative? I mean, there's 15 negative targeting trials to one Sprint trial. And now there has actually been several more trials that have been positive in that targeting space since Sprint, but still the majority of the trials are negative in that area. And I still find it to be a fascinating question still of, why was Sprint so positive? Why were other trials negative? There were some differences about how Sprint trial measured blood pressure. For example, the blood pressures were done in an unattended fashion in the Sprint trial. And it's speculated that when you do unattended blood pressures, there's a difference by about 10 millimeters of mercury compared to attended blood pressures. So you could make the case that if Sprint was done exactly the same way that Accord was done, or other trials that did targeting different blood pressure numbers, that maybe those targets weren't 120 and 140, they were more like 130 and 150. Does that make sense? But I can also tell you that there's reasons that might not be true, because only about 2/3 of patients in Sprint had unattended blood pressures, and there doesn't seem to be a difference in treatment effect, whether their blood pressures were attended or unattended. So it's just one of these open questions. I mean, I still don't really know the answer to it. I think you have to take Sprint, though, in totality with the rest of the evidence that we have. One thing to know about Sprint is, even though it was advertised as patients were higher cardiovascular risk, to get into the trial, they were actually very healthy patients, and in fact almost had no comorbidities other than just their age. Because if they actually had coronary disease or congestive heart failure, things of that nature, they wouldn't have been able to be enrolled in the trial. And when you look at like the Charlson index scores of the Sprint population, which we've done in some of our research on treatment effect heterogeneity and comorbidity, the Sprint population is a really healthy population of people. And I wonder if just that had a lot to do with it. So for example, the Charlson comorbidity scores of Sprint are shifted to the left compared to the Accord trial. So like, if you have two distributions, they don't overlap perfectly. Sprint's to the left and Accord is to the right, where sort of the meat of their populations lie. And, I mean, could that contribute? I think it's possible. I mean, the patients in Sprint didn't have diabetes. Patients in Accord had diabetes. They could have diabetes with end organ damage. So I think they were a more sort of morbid population of people, but we still don't know. And I think if you look at all of the targeting trials, we get maybe a very weak signal of benefit that's not statistically significant for that 120 number. And there's definitely heterogeneity within the trials in that result. So I think it's an area where it's sort of unanswered at this point.
So this sort of relates to your medical conservative approach to the practice of medicine. A few years ago, you and John Mandrola, Adam Seafew, and Vinay Prasad wrote an article, which I think you spearheaded, according to John Mandrola. So why did you choose to write that article? And maybe talk a little bit about that approach versus the approach of others in the field.
Yeah, so the background is pretty interesting. So I guess about 5 years ago or so, maybe even a little longer, a trial got published, the Scott Hart trial, which is basically something that is sort of still an evolving area in cardiology, is that for people that have suspected coronary disease, is it better to do functional stress testing to make the diagnosis? So your traditional sort of exercise treadmill test, stress echo, nuclear perfusion study, or is it better to do an anatomic imaging test with coronary, coronary angiography with CT? And my concern with coronary CT was that it was going to lead to overdiagnosis, and it was going to lead to sort of unnecessary downstream procedures. And we've written about that and published some things on it. So Scott Hart had already been out, and we had already been aware of the initial results of Scott Hart, and it was included in a meta-analysis that we published in JAMA Internal Medicine, maybe a year or so before. So anyway, this particular publication was like the 5-year results of Scott Hart. And what it reported was that there was a significant reduction in non-fatal MI in the group that was randomized to the cardiac CT approach. And without getting into the specifics of the trial, because I don't know that your audience would be interested, but we thought that the treatment effect that was being reported was sort of ridiculous, because it was like a massive risk reduction that was like 2 or 3 times higher than like any of the best therapies in cardiology. And what likely happened was just the trial wasn't really powered for that endpoint. They just sort of got lucky because they were dealing with sort of low numbers of events. And, when it's not a primary endpoint, you're not powering for something like that, you can very easily just confuse like noise for a real signal. So I think that's all it was. And the evidence of that is that there wasn't really enough of a difference in management between the two groups to drive any significant reduction in non-fatal MI. And so we had the trial came out, people on Twitter and other areas were sort of giving their opinions on things. And, we had put our opinion out there. I don't remember if I was interviewed at the time by like Medscape or something like that, but, several of us were. And so in response to some of the things that we had said, a medical journalist wrote a piece basically, and in the piece criticized people like me and John and others, and was like, no matter how good a trial is and how good the results are, you're always going to have these assholes that are just never happy and just always just, trying to like rain on people's parade. And I just found it like infuriating, because the piece essentially didn't try to address the technical issues that we raised, which to this day I still believe are correct and haven't really been refuted. And it was just sort of like maligned us as being people that were haters. And it just made me really mad. And so I'd always sort of struggled with the notion of like, I hated being called like a cynic. I always felt like I was skeptical, and that's a good thing. I always felt like skepticism is the foundation of like scientific thinking. And just because that might lead me to question things doesn't necessarily make me a cynic. It doesn't make me a hater. And so I just started thinking that, we have to like put something out there so people understand where we're coming from, because like, it was just like, what was written was just, it just made me so angry, because it didn't try to address any of the actual criticisms that we were raising. It was, and so it just totally attacked us. And so I just wrote off this bullet point email to John, and it was really out of anger, to be quite honest. I was like, and I was basically almost putting out like this sort of philosophical defense of like why, people like us think the way that we do, and that this isn't something that, I don't know that there's a right or a wrong answer for what's the right way to think, but this is just sort of like a natural approach. And I relate it back to like Thomas Sowell. He wrote like Conflict of Visions, and there's just differences in the visions of people that tend to be on the right and the left from a political standpoint. And this didn't have anything to do with politics. It was just that, there's, I think, a difference in our vision of sort of how we see medicine and the role of medicine and doctoring. And I just wanted to like sort of write that in a semi-coherent way, because I think a lot of people actually agree. And it was almost just sort of like a way to get that sort of set of beliefs and visions down in this sort of coherent fashion, and so I just like rattled off these bullet points to John. I had no idea what was going to happen with them. And then John was like, well, why don't we make this a paper? And I was like, yeah, good luck, man. Nobody's going to publish this. It'll get shot down in like a second. And he didn't necessarily agree. He's always been a little more optimistic than me when it comes to that sort of stuff. So he just made the bullet points into like formal sentences. And then I said, why don't we like pass it to somebody else and just see if they don't think this is like crazy and it's worth submitting. And at the time, I didn't formally know Vinay or Adam. I mean, I knew of their work because I had sort of been interested in similar topics for my whole life in medicine, but we didn't have any real connection. So we sent it to them, and they both really liked it. And it's funny, Vinay's only criticism was, you might want to consider taking the word conservative out of there, because, you don't want to like get people too hung up on that word. Vinay's like, I'm not a political conservative, but I guess I'm a medical conservative, but like, I don't want people to sort of dismiss it because they get hung up on terms. And I was like, no, it works. And then Adam was like, no, nobody should be so silly as to get hung up on a term without, trying to understand what it means. And so we ended up, using that term. And like, still to this day, the major criticism of the piece is like from people that are like, I really like it, but I hate that it makes me feel like a conservative or something like that. So it's still funny. And, every time like I get an email or something, I always, send it to Vinay. But yeah.
So I want to make sure that we're all talking about the same thing when we say medical conservatism. So my understanding is that it's someone who is not going to rush to the newest study, often one sponsored by a pharma company, to utilize a new intervention unless there's sufficient evidence-based medicine that they believe promotes the practice. My confusion comes with two different things that medical conservatism can come to mean. The first is, and I think that your example of the coronary CTA versus stress echo is a great example, where you can look at that and say, okay, we have a patient, we are going to give them a coronary CTA versus a stress echo and look at the difference in outcomes. So which of these is more effective in providing good quality care? The alternative way to look at that is comparing those same two things and saying which is going to cause a higher burden of cost utilization. So when we talk about medical conservatism, which of those are you referring to, the cost element or the individual effectiveness?
So I think that both elements are involved, but fundamentally it's about the effectiveness. And it's always been about the effectiveness to me, but it can't truly be sort of separated from cost. And I guess that's some of the where I go back to like some of the Hayekian perspectives that I have, which is I do sort of think about what represents a true advance, and is it sort of what I would consider like flat of the curve, meaning that it's a lot of money to confer like a very small clinical benefit, and is that sort of practical? And even forget if being practical or not, if somebody was just fully informed, would they really want it? Like, so let's say, for example, something like a coronary CT versus a stress echo. I mean, there is difference in cost, but it's not tremendous. It's probably like on the order of, I would say, $500 to $1,000 on average, the difference. But, would a fully informed consumer, want to spend the extra money if it was sort of coming out of their own pocket for a test? Like, let's just say theoretically, if it didn't improve their outcomes. I mean, my thinking on that is like, no, why would anybody want to do something that costs more that wasn't like measurably better? And I don't just mean, we can, get things that are statistically significant, but sort of like clinically irrelevant all the time. And I think that average people sort of have a sense of like, what's real to them and what's sort of theoretical. And so like, but that being said, I mean, I don't really have a problem with people who want to spend more for sort of very small incremental advances, particularly if they want to do it with their own money. I have no problem with that. I think from a societal standpoint, where we don't really have honest conversations about what that means in terms of like, the cost of healthcare and the cost of premiums and things of that nature. But like, yeah, I don't fundamentally have a problem with people wanting to spend more for more, even if the more is not much more. My main issue has to do with effectiveness and how are we judging effectiveness, but cost does, factor into that equation as well. But most of the cases that I make, for example, against like the GDM, how we use GDMT in patients with heart failure, it really has nothing to do with cost. I mean, it has everything to do with safety and efficacy from my perspective. And I think the same, I feel like, is true even for something like coronary CT versus functional stress testing. Although I would draw a distinction between like nuclear versus stress echo and exercise treadmill testing.
Maybe it's worth also discussing how conservatism is typically used colloquially in making a medical decision. So, a patient comes into the emergency room, they are tachycardic, they don't really have risk factors for PE. Some emergency medicine physicians I've seen order the PE just in case, just to be conservative about it. They want to just make sure that they don't have the PE. Whereas other people would talk about not ordering the PE, the CTPE, as being the more conservative choice. Yeah, she doesn't have risk factors for this, or let's skip the PE study because we don't want to cause harm by over irradiating. But I think that ends up being another way that people use conservative. How does your definition of medical conservative square with that?
It's exactly the opposite, but I know what you mean. And I felt like when we wrote it, I think, if you read that piece, it's fairly clear what we mean. But if you don't read the piece and you just hear the term, I can certainly understand why you might think it means the opposite. And I actually have a funny story. Before I got officially hired for my first job after fellowship, I wanted to stay on at Penn State. I wanted to do academics, but like I didn't know for sure. So I had to interview for some other jobs. So I was interviewing with this private group in the state. the guy was sort of talking like, what's your practice style? And I said, I'm pretty conservative when it comes to managing patients. And he's like, that's great, and he totally meant it the opposite way. He's like, I never, if there's any chance that, a person could have coronary disease, I want to know. And, it was all about like doing 30 stress tests a day. And it was like, oh, we don't mean the same thing.
Yeah, yeah. And I think that to Prasad's point, the term ends up being confusing also if you think about like what a medical liberal is. And although I agree with many of the points that you make throughout that piece, I feel like the issue that ends up coming up with the term that you use for it is that no one is going to identify as a medical liberal. Like there is no opposite of that, even though people practice, you can see in the way people practice that everyone thinks that they're being conservative, if that makes sense. but the specific way that you mean it is in a particular sense. So I guess, do you see any like case against being a medical conservative? I mean, the thing that I think about regarding this topic has to do with more of like a higher regulatory stance. So like the FDA, should the FDA approve more drugs or fewer drugs? Do they demand too much evidence before they say doctors can use a certain medication? Or do they not ask for enough? So, Alduhelm is the more recent example where people are very upset that they approved a drug that very few people think is actually going to work and it costs a lot of money. But on the other side of that debate, you have more libertarian types talking about the invisible graveyard of, if the FDA demands too much before they approve something, such that researchers won't even investigate a certain medication, or it takes an extra 5 years, then you're causing 5 years worth of people to suffer and die as a result of that medication not being approved. So I'm just sort of throwing out a bunch of stuff to get your take on it.
No, so yeah, I'm actually not big on the regulatory side. I think that's probably a big difference between like Vinay and me, for example. I think John is sort of in between. I very much still am like a libertarian at heart when it comes to a lot of things. So when I look at the application of EBM, it's more about from like a personal and professional standpoint, as opposed to from like a regulatory standpoint. And I've always sort of had this impression that as physicians, it's our job and our duty to appraise the evidence at a high level for ourselves and make and come to decisions about how we're going to use things. I'll just leave it at that. I mean, I'm not so much in, I don't think like more regulation would necessarily lead to better care, more efficient care, or even, so anyway, so I'll leave it at that. But I wanted to just like piggyback. You mentioned this idea of like people probably wouldn't say that they're a medical liberal. And so I guess, I've thought a lot about like the visions. And so if I said that, medical conservatism is sort of one vision, I think, and I guess at the heart of that vision, I would sort of put skepticism, which again, I think is like the foundation of scientific thinking. So I think the other vision is I guess, what would be the opposite of sort of skepticism? Maybe like an optimism, and like this sort of progressive vision, not in the political sense, in the sense of like the heart of medicine is about this constant march for progress to sort of stamp out disease at all costs, and be constantly improving health and wellness, right? And I don't think that that's wrong. It's just a different vision. And so like, to me, I mean, and this is going to sound weird, but I don't really care that much about progress for the sake of progress. I care more about knowing, what's right. I don't really care so much about, this notion of like, I mean, we're all going to die. We're all going to suffer. And there's many ways to do that medically, psychologically, like it doesn't matter if we increase people life expectancy with heart failure another 6 months. I mean, we haven't ameliorated suffering in any real way. We haven't gotten rid of the problem of death in any real way. It's a different way of looking at the world, so it's sort of like caring for people and being a doctor is just fundamentally different than just providing more things that might make them live longer, right? And so like it's why when somebody presents new late-breaking research at a meeting that's positive, I feel no compulsion whatsoever to stand up and cheer. I mean, it's just sort of like silly to me. What am I cheering about? Like I don't care whether the thing is positive or negative. I just care about knowing whether it works and how I'm going to apply it to my patients. But I think that most of that meeting involves people that stand up and cheer. And I'm just sort of going, that's so weird to me. Like, why do they feel that? And I don't think that they're being disingenuous. I think they really feel those emotions. Like, yes, medicine, we're making progress, and so I guess if you're to say, what is like the expense, so what does that vision have to offer? Probably if we didn't have that vision, I don't know where we would be as far as a lot of our innovation and progress, but it's sort of, it needs to be kept in check. And maybe that's where the other sort of vision comes into play, which is, that sort of, stand athwart history yelling stop sort of thing, which is what started like that piece on medical conservatism. And I mean, I think if we're like being honest with ourselves, we probably do actually fall along one of those visions more than the other. And there's probably a continuum in between. But like actually recognizing those visions and having debates specifically between people who are on opposite ends, I think would be really informative, and it could potentially move like, I don't know. I think it would be really helpful if we actually acknowledge those things and sort of acknowledge the underlying biases in our thinking that are there, because it's not just all black and white EBM. I mean, it's, somebody could disagree with me, for example, when it comes to how to use GDMT in a patient with newly diagnosed heart failure. And, I can't prove that they're wrong and they can't prove that I'm wrong, but like how, those sort of visions conflict and how, we apply those to patients matters. And I guess I'll close it by saying that I don't think there's a right answer. I think the right answer is about what does your particular patient that you're treating want? Because I think patients have their own visions, and in making people happy, it's about providing people the care that they want, and I guess, the one thing I would say is that, I think understanding that, and trying to almost teach physicians how to align with that. And like, we almost have to be actors, because sometimes, like my patient practice is probably composed more of people who like my style than don't. They've sort of gravitated to me and stuck with me. My satisfaction scores are pretty high, but like physicians who are completely the opposite of me also have high satisfaction scores. They have large patient groups who've sort of stuck with them over time, and I think just maybe appreciating, what our styles are and how that makes us relate to patients and provide care to patients. I think that would really, be like an optimal approach for doctoring. But I think we can't act like there's only one right or wrong way. There's probably not. And probably the best way is different depending on the patient. And if the goal is to just make patients happy and provide them the care that they want, we should have some appreciation of those differences. Does that make sense?
Yeah, yeah. If the patient wants antibiotics, you give them antibiotics, right? You get your satisfaction scores up. No, I understand exactly what you're saying.
Yeah.
So I want to talk briefly about COVID, and another thing you mentioned in your medical conservative piece, or maybe medical visions piece.
That hasn't been written yet.
Yeah. To be published next year.
Yeah.
Don't worry, we won't scoop you.
So if you write it, I'd be happy to be co-authors. I'll tell you one thing: as I've gone on, my ability to write has gotten so slow that it's pathetic.
Well, that's why they made GPT just for you. Just bullet point, expand to a whole essay, and press the publish button on Substack or whatever. So a great quote from your piece, which I'm going to read, is: too often content expertise becomes a synonym for devotion to the prevailing model or theory. And then you go on to describe how content expertise can sometimes run counter to what you actually would want in a doctor. For example, the doctor who's very, very good at putting in ICDs may not be the person to consult in every circumstance about when ICD should be implanted. And this relates, I think, a little bit to COVID. You heard a lot of complaints about experts not in virology or immunology or epidemiology commenting on some of the evidence around different medications during COVID. A lot of stay in your lane. So I guess, what are your thoughts on that as it relates to COVID and what we've learned over the last few years about how serious people are about evidence-based medicine?
Yeah, well, yeah, so I think that COVID sort of revealed some people's true colors, I guess, in terms of devotion to evidence-based medicine. And I don't know if maybe some of that was just related to fear, which, possibly could be. I don't know. I think a lot of it had to do with how political the issues got, very early on. And that, I think, interfered with some people's thinking. Yeah. But I think COVID was sort of a disaster from an evidence-based medicine standpoint, right from the get-go. We did a systematic review and meta-analysis a couple of years ago. It was published in the European Journal of Medicine. And basically, the idea was some guys had approached John Mandrola saying that we got this tool that allows us to, for all published articles, it tells us the time to submission to publication. And they thought it was pretty neat. And what they had found was that COVID articles were getting published incredibly fast, from time to submission to peer review to online print. And I think, they inferred from that the quality of the research was very poor. And John had sort of asked me to get involved. And my question to them was, you may be right. I mean, I get the instinct that if the research is being published very quickly, that it may not, the sort of the quality checks might not be there during the peer review process. I said, but if that's the concern, I said, I wouldn't just infer it from time to publication. I would actually assess the quality of the studies and do a systematic bias assessment. And so what we did was we took the top 100 COVID articles according to their altmetric scores, And then we went back a year, and for each article, we matched it with another article from the same journal with essentially the same research design. And then we had two people do bias assessments, and the bias assessment tools were different depending on the research design. But the results were that the COVID studies were much more susceptible to bias than the non-COVID studies. And I mean, that was, I think, my sense of things, but I wasn't really sure what that was. I wasn't sure how that research was going to pan out. I mean, I wouldn't have been shocked if we had just sort of found high susceptibility to bias sort of across the spectrum, so it was surprising how sort of low quality the COVID studies were. And these were like big hitting studies that were affecting the way that people were being managed in real time. And I think as time's gone on, a lot of these things have gone on to be reversed and found that they didn't work, and maybe even making things worse. And so, yeah, I mean, I think COVID was not a win for evidence-based medicine in general. But I think it shows what happens when people are very afraid, when there's a lot of hype, when things get political. That appraisal of science, sometimes takes a backseat.
On a previous episode, we had Nir Barzilai, who's an endocrinologist up at Einstein. He's running the TAME trial, which is using metformin in older adults to try to prevent aging, sort of I guess, more of a medical liberal approach. In that discussion, he brought up how statins are associated with diabetes. You've done some work on this topic. What are your thoughts on the association between statin use and diabetes?
So I think there's a real effect. I think it's very small. And I don't think it's really clinically too terribly relevant. I think the RCTs do show a small effect. It's on the order of like a number needed to harm of like the 200 to 400 range to cause an incident diagnosis of diabetes. The observational studies, though, have crazy numbers in them. I mean, like on the number needed to harm of like 10, 20 range. And we actually published something last year where we did sort of an alteration of the study design, which we thought would exclude selection bias by we first looked at a group of patients who had been exposed to statins and then weren't. And, we controlled for the things that you would control for. And we found that the odds of developing diabetes was like 2.2 in the statin group. And then we actually took patients all from the statin group, and we split them into continuers and discontinuers by 6 months of statin therapy, because we know that a lot of people discontinue statins for the majority of people that discontinue them don't have any specific reason. It might be muscle aches and pains. It might be just they didn't feel like taking them anymore. They heard they were bad. They don't feel like they're helping them because they don't feel any better. And so when we actually looked at those two groups of patients, we found that the odds of diabetes was essentially identical in both groups. It was still mildly higher in the statin group, and the difference in risk was about what the RCTs would have predicted that it was. So, I do think that it is a real effect. I do think it's small. However, I think if you're looking at just like primary prevention, it's something to consider in terms of the equation.
All right, just a couple more questions. These are some rapid fire questions for you. What is one scientific article that you believe more physicians should be familiar with?
I mean, John Ioannidis, sort of the main paper on, 90% of research results are false. I think that's a big one. I think, Prasad and Sifu's medical reversal stuff is really big. I think some of the stuff from like Gil Welch on overdiagnosis of cancer is, really important stuff. I would say those three.
If you had unlimited funds for a single RCT, what would you study?
There's a lot of things. I would probably study most common therapies we use in cardiovascular medicine on patients who are older and with multiple comorbidities. And I would separate them into stable outpatients and patients who were newly diagnosed and hospitalized.
Last question. What should we have asked you during this interview, but we didn't?
I don't know. I mean, you guys did a really good job. You really came prepared.
Well, next time we'll have to have a little bit of extra time to talk about boxing. But
yeah, see, I love to talk about that. So that's not empirical, that's just totally subjective. So I'm not so measured in how I talk about that.
Well, Drew, thank you so much for joining us on the External Medicine Podcast. For people that are interested in learning more about you or your work, where would you direct them on the internet?
Well, I started a Substack recently. I'm not as active as like some of the people that I associate with as far as social media goes, but I guess I would say Substack or Twitter.
All right. Thank you so much, man. I really appreciate you coming on.
Yeah, that was fun.
This podcast is for educational and entertainment purposes only. We do not endorse any healthcare providers or treatments. Our views do not represent the views of any official organization or institution. If you'd like to support us, subscribe to this podcast wherever you get your podcasts. Leave us a review, preferably a phenomenal review. Visit us at externalmedicinepodcast.com and tell your friends.